Welcome to the module training for primary care medical officers in Selangor. This module is created to guide you in managing hypertensive disease in pregnancy. Hypertensive pregnancy disorders complicate 10% of all pregnancies. This covers a spectrum of conditions such as chronic hypertension, gestational hypertension, pre-eclampsia, and eclampsia. In Malaysia, hypertensive disorders in pregnancy has remained in the top 5 causes of maternal death right from 2017 up until now. About 1 in 10 of women have high blood pressure in pregnancy, and out of them, 20% are those that have had chronic hypertension, and the remaining 80% are those that occur in pregnancy. Let us now look into the definition of hypertension in pregnancy. It is defined as a blood pressure of 140 by 90 mm mercury or more taken after a period of rest on 2 different occasions. If the blood pressure is severe, and by that we mean a blood pressure of more than 160 by 110, then the diagnosis should be confirmed within 15 minutes. Proteinuria itself is quite common in pregnancy. So when do we say that it is an abnormal proteinuria? For starters, proteinuria should be assessed using an automated dipstick urinalysis whenever possible. We say that it is significant proteinuria when it's 2+ and above. Please be reminded that proteinuria is not required for the diagnosis of preeclampsia. And massive proteinuria, when present, is associated with more severe neonatal outcomes. Let us now look into the classification of hypertension in pregnancy. Broadly speaking, we divide it to 3 different categories. Firstly, pregnancy-induced hypertension or gestational hypertension. Second, chronic hypertension, also known as essential hypertension. And lastly, eclampsia. We will be going through each of these categories in detail. Pregnancy-induced hypertension. This is when the hypertension occurs at the 20th week of pregnancy or later in a previously normotensive woman. It may be associated with proteinuria, and please note that preeclampsia may develop later in 25% of these cases. Chronic hypertension. This is when the hypertension predates the pregnancy or is diagnosed before 20th week of pregnancy. It can be essential or due to secondary causes, which is uncommon. Please note that superimposed preeclampsia will complicate up to 25% of these pregnancies as well. What is preeclampsia? This is when, with the presence of hypertension in pregnancy, there is one or more of the following criteria. First, proteinuria. Second, any other forms of maternal dysfunction involving other organs, such as when the creatinine is more than 90, ALT, AST more than 40, or the presence of neurological complications or hematological complications. In addition to that, if there is the presence of uteroplacental dysfunction as evidenced by intrauterine growth restriction, abnormal umbilical artery Doppler, or stillbirth. A more severe form of preeclampsia is when there is severe hypertension not responding to treatment or the presence of any of the following symptoms, such as ongoing or severe headaches, visual scotomata, nausea, vomiting, epigastric pain, oliguria, deterioration in lab parameters, failure of fetal growth, or abnormal Doppler finding. Now, I'm sure all of you would have heard of HELLP syndrome. What is HELLP syndrome? It is a severe form of preeclampsia manifested by hemolysis, elevated liver enzyme, and low platelet count. Looking into the third category of classification of hypertension in pregnancy is eclampsia. This is when there's an occurrence of convulsion in a patient with hypertensive disease in pregnancy. A syndrome of preeclampsia nearly always precedes the convulsions, but may occur even in a modest hypertension without proteinuria. Before we get into the management of different categories of hypertension in pregnancy, let us look at how we can prevent the occurrence of preeclampsia in select patients at risk. These are target groups who will require aspirin from 12 weeks gestation until birth of the baby. In addition to that, we would start calcium carbonate 1 gram BD by at least 20 weeks, a combo also known as Pre Eclampsia prophylaxis. Those categories on the left side of the table require only one risk factor to be started on PE prophylaxis, whereas those on the right require 2 or more. We consider high risk factors in patients who have had hypertensive disease in previous pregnancy, those who have chronic kidney disease, autoimmune disease, type 1 or type 2 diabetes, or those who have chronic hypertension. And moderate risk factors are those who are in their first pregnancy, age 40 years or older, with a BMI of more than 35, pregnancy interval of more than 10 years, presence of family history of preeclampsia, or those who are currently having a multi-fetal pregnancy. We are now going into the management of chronic hypertension in pregnancy. At booking, we will need to review their pre-existing antihypertensive medication and convert it to those safe in pregnancy such as methyldopa, labetalol, or nifedipine. ACE inhibitors, ARB, and thiazides are not recommended in pregnancy. We should do a dating scan for them to date and confirm viability and number of fetus. As mentioned before, these patients need to be considered high risk for preeclampsia and should be started on preeclampsia prophylaxis. Please note that target BP control while started on antihypertensive agents for these patients are systolic 120 to 135 and diastolic 80 to 85. Sometimes it is a dilemma as to which antihypertensive agent we should start for these mothers. I hope the following guide will be useful. In mothers who are at less than 20 weeks, methyldopa is preferred. In mothers who are at 20 weeks and above, either methyldopa or labetalol can be used. If the blood pressure is still uncontrolled, nifedipine can then be added. It is norm for us to start with monotherapy and increase gradually till maximum dose. The following parameters must be measured: blood pressure, weight, urine protein. A baseline PE profile should be done. This includes full blood count, renal profile, serum uric acid, liver function tests. In addition to that, we must educate and advise the mother to return immediately if she has symptoms of preeclampsia. This slide summarizes common antihypertensive drugs and doses used in pregnancy. For methyldopa, starting dose is usually 250 mg TDS up until 1 gram TDS. Labetalol can be started at 100 mg TDS up to 2.4 grams per day until blood pressure is well controlled. And nifedipine can be started at 10 mg TDS up to 20 mg TDS when blood pressure is poorly controlled despite maximum doses of methyldopa with or without labetalol. On subsequent antenatal follow-up, it is important for us to ask these mothers for symptoms of preeclampsia at every visit. In a way, we will then be empowering these mothers to identify potential red flag symptoms. We must do maternal surveillance with blood pressure, weight, and urine protein. Home BP monitoring, if available, is useful. We must then refer these patients at 34 to 36 weeks to our ONG colleagues for plan of delivery. However, if at any visit, preeclampsia or fetal compromise is detected, then an emergency referral is done. These mothers are considered high risk and must be emphasized for hospital delivery, the timing of which depends on control of hypertension and if on medications. In the postpartum period, the antihypertensive medications can be continued if necessary. We aim for a blood pressure of less than 140 by 90. The monitoring of blood pressure should be continued after delivery with the help of health clinics. And let's not forget to emphasize on family planning during the postpartum visit. We have reviewed the management of chronic hypertension in pregnancy and are now moving on to the management of gestational hypertension and preeclampsia. At booking, it is important for us to identify those patients at high risk of preeclampsia. This will be following the table I mentioned earlier, and if indicated, preeclampsia prophylaxis should be started. At the diagnosis of gestational hypertension, we must first ensure that correct blood pressure measurement was conducted. If the blood pressure is more than 140/90 on 2 different occasions, then an antihypertensive is indicated. A baseline PE profile should be done in addition to the urine FEME. If the mother has mild gestational hypertension, then she can be managed at the HELLP clinic. However, moderate and severe gestational hypertension are indications for referral. Let's not forget to educate and advise mother to return immediately if she has symptoms of preeclampsia. We may need to diagnose a mother with preeclampsia when she develops hypertension with new onset of proteinuria or significant growth discrepancy from serial growth scans. In this condition, we must refer to the ONG specialist for hospital admission. When a mother presents to us with severe preeclampsia or eclampsia, it is important for us to stabilize her blood pressure first. Following that, arrangement for hospital admission must be done after informing the ONG specialist on call. We must give a loading dose of intramuscular Mexalf before transfer. A CBD must be inserted after the loading dose. And why is that? We will discuss this later. If, let's say, the patient is unwell or we are unable to resuscitate this patient or transfer them promptly, certain hospitals offer obstetrics emergency retrieval team support, and this can be utilized. Upon discharge from the hospital on subsequent antenatal follow-up, the management of these patients is somewhat similar to previous categories. We ask for symptoms of preeclampsia at every visit. Maternal surveillance must continue as per usual. We should order for a preeclampsia profile at every trimester. BP monitoring will depend on the severity of the blood pressure. Mild cases might just require weekly monitoring, moderate cases at least 2 times a week, and of course, if severe or symptomatic hypertension, then hospital admission is indicated. The babies of these mothers are at risk of developing intrauterine growth restriction. Hence, close fetal surveillance must be done using measurement of symphysiofundal height and also in making sure that the mother charts her fetal kicks. We should also do serial ultrasound to monitor fetal growth and amniotic fluid monthly starting 28 weeks. At 34 to 36 weeks, these patients should be referred to the ONG clinic for plan of delivery if not already under hospital follow-up. Delivery is usually outlined by the ONG specialist at about 36 weeks. And it goes without saying that these mothers need a hospital delivery. Postnatally, we must continue to monitor the blood pressure after delivery until 3 months postpartum. The frequency of this, of course, is individualized. For those not on treatment, consider starting if blood pressure remains more than 140/90. And for those on treatment, the dose of antihypertensive should be continued and tailed down gradually. Consider reducing antihypertensive if blood pressure is less than 120/80. It is advisable that we should not stop the medication abruptly. If the patient was on methyldopa antenatally, stop after delivery and change to an alternative treatment if necessary, such as nifedipine, amlodipine, labetalol, or atenolol. The reason for this is that methyldopa is associated with a risk of postpartum depression. If the blood pressure remains more than 140/90 after 3 months postpartum, then chronic hypertension must be considered. We must discuss options of contraception with the patient. Breastfeeding, as always, is encouraged. Antihypertensive acceptable in breastfeeding are such as nifedipine, labetalol, captopril, enalapril, atenolol, or metoprolol. We must avoid diuretics or angiotensin receptor blockers. Just a word on family planning. Now, these mothers are considered high risk and hence contraception advice should begin to be emphasized even antenatally. We must advise them for good spacing and to plan their pregnancies well. Over here, I would like to introduce the use of WHO Medical Eligibility Criteria Wheel for contraceptive use to determine what kind of contraception would be best suited for them. The methods on this wheel are rated on a scale of 1 to 4, 1 being use the method in any circumstance and 4 being the method is not to be used. In those patients with mild hypertension, we can advise them for progesterone-only pills, Implanon, levonorgestrel or copper IUD, or even intramuscular depot. However, a COCP is not recommended unless other more appropriate methods are not available or acceptable. In those patients with severe hypertension, it is best for them to be on a copper IUD as it holds no hormonal bearings. They can also choose between progesterone-only pills, Implanon, or levonorgestrel IUD. An intramuscular depot is not to be used unless more appropriate methods are not available or acceptable. Please note that COCP is given an MEC4, which basically means should not be used at all. We will now be looking into the management of different emergencies involving hypertensive disease in pregnancy. Let us first look at the management of severe hypertension. What is severe hypertension? It is when the blood pressure is more than or equals to 160 by 110. In these scenarios, blood pressure can be repeated every 5 minutes for 15 minutes to confirm the diagnosis. It is good practice to notify the FMS after one severe blood pressure value is obtained to alert them regarding the case in the clinic. Upon making the diagnosis of severe hypertension, we should first call for help from our colleagues. We can then designate roles to our team to monitor blood pressure and administer drugs. We must ensure that the mother is given bed rest and the side rails are kept up. The reason for this being is that if she were to develop an eclampsia attack, the last thing we would want is for her to fall off the bed. We can then administer antihypertensive, and the choice for this being either nifedipine or labetalol. An IV access can be placed, and do not forget to document all medications as well as monitoring that has been done. The algorithm for administering oral nifedipine is as follows. We first start with a 10 mg dose, following which the blood pressure should be repeated in 20 to 30 minutes. If the blood pressure remains at severe hypertension, then another dose of oral nifedipine 10 mg can be given. We aim to get a target blood pressure range of 140 to 150 systolic and 90 to 100 diastolic. We then repeat the blood pressure in 20 to 30 minutes again. Once blood pressure thresholds are achieved, do not forget to continue monitoring the blood pressure accordingly. Moving on to the next possible emergency of severe preeclampsia. As with any emergencies, first call for help. Do note that there are many things for you to do at the same time, and it can be overwhelming to do it all alone. As mentioned before, designate roles, ensure bed rest for mother, and get an IV line set. In this scenario, we will have to give a seizure prophylaxis of Maxalf. If her blood pressure is high, then an antihypertensive therapy must be given. If the mother is at less than 34 weeks period of gestation, then she should be given antenatal corticosteroids. A CBD should be inserted and documentation should be done. I mentioned a seizure prophylaxis of magnesium sulfate. What is it for? It is given in two different scenarios. Firstly, for treatment of eclampsia, and secondly, to prevent eclampsia in severe preeclampsia. With regards to Maxalf administration, I would like to bring to your attention this Garis Panduan on your right. In this guideline, it has mentioned that the following categories of health staff are eligible to give the injection of Maxalf. This consists of pakar perubatan keluarga, pegawai perubatan, jururawat kesihatan awam atau jururawat terlatih, penolong pegawai perubatan. Bagi jururawat masyarakat, mereka perlu menjalani credentialing dan privileging mengikut keperluan setempat. This is important because a severe preeclampsia or eclampsia can occur anywhere at either a health clinic or a clinic desa without the availability of a doctor present. The purpose of magnesium sulfate is as a seizure prophylaxis and not as an antihypertensive agent. The possible routes in which it can be given is via IV or IM, but it is common practice in health clinics to be given via the IM route, on which we would start with a 10-gram loading dose followed by 5 grams every 4 hours in alternate buttock if the patient hasn't arrived in the hospital. It is important for us to monitor and look for signs of toxicity, which we will be going through later. How should the magnesium sulfate be administered? The picture on the right shows an actual vial of magnesium sulfate which contains 2.47 grams in 5 ml in 1 ampule. Prior to giving, contact your FMS or ONG specialist. However, if you are unable to contact in cases of emergency, go ahead and give it and later inform. The pictorial on the right shows the method of administering MagSulf. 5 grams of MagSulf plus with 1 ml of 2% lignocaine is inserted into each syringe and injected on the upper outer quadrant of each buttock. The following parameters must be monitored after the administration of MagSulf. First, the respiratory rate and pulse oximetry, blood pressure, maternal pulse rate hourly, urine output hourly, and reflexes at the completion of the loading dose and then every 2 hours. The patient has developed MagSulf toxicity if there is evidence of respiratory depression, muscle paralysis, or if the reflexes are absent. If this is suspected, then immediately cease the infusion and administer the antidote of calcium gluconate 10%, 10 ml in 100 ml of normal saline via infusion over 10 to 20 minutes. We are now moving on to the management of our last emergency, eclampsia. The aims of treatment in eclampsia is to treat the convulsions and prevent a recurrence, to control the blood pressure, stabilize the mother, and deliver the fetus. So what should we do if a mother has come to our clinic in eclampsia? First of all, stay calm and don't panic. Call for help. And then we should go back to the basics of our BLS to protect the airway and improve oxygenation. Attach a pulse oximetry and put her on a non-rebreathing oxygen mask. Put her in a lateral decubitus position, do a back mask ventilation, and if suction is available, proceed. Fetal monitoring must be continued using the usual daptone. IV access should be placed to allow administration of drugs and resuscitative fluids. MagSulf must be given. Antihypertensive therapy can be given if indicated. An indwelling urinary catheter should be inserted to monitor urine output. And don't forget to debrief the patient, the family, and the obstetric team regarding the occurrence. I cannot emphasize enough on the importance of documentation regarding all medications as well as monitoring done. Let us not forget that the safe transport of a patient is as important as management of an emergency in the health clinic. We must first determine if the patient is stable for transport. Are all my equipments available and functioning? Who will be accompanying the patient to the hospital? Is my transport available promptly? What kind of monitoring should be done during the transport? And all monitoring should be followed by proper documentation. It is good practice to inform the labor room personnel of the receiving hospital prior to the referral. We have reached the conclusion of my talk today. Hypertensive pregnancy disorders is a common occurrence. Early recognition and prompt treatment can prevent the development of both maternal and fetal morbidity and mortality. Hence, it is important for us to offer adequate treatment even from the state of pre-pregnancy. The following are the references used in my presentation. Thank you and have a good day.